Alexandra. I'm a PhD student at Leiden University in the Netherlands, and today I will be discussing the results from my research in which I compared Beninese and Gabonese women's local perceptions of women's reproductive health with international health priorities in each one of those countries. I'll begin with my research aim. It was to examine how closely African women's perceptions of women's health care, knowledge on how to treat major health ailments, and plant use practices, so which species, how closely these three align with the priorities of national and international health programs. Well, to begin, I'll talk a little bit about the statistics that are used to inform the international programs and the perspective of women's health care from those organizations. Well, to begin, the maternal mortality ratio, which is defined as the number of deaths per 100,000 live births, is 350 in Benin and 230 in Gabon. The top causes of maternal mortality are number 1, hemorrhage, number 2, sepsis, which is severe infection, and number 3, high blood pressure. Now, these conditions have led national governments, international organizations, and donor countries to begin the Millennium Development Goals with the objective of reducing severe poverty by the year 2015. Goal number 5 of the MDGs is to improve maternal health care, which is hoped to be done by reducing the maternal mortality ratio and achieving universal access to reproductive health. So this is very much the WHO perspective, the MDG perspective. But what about local communities? How are women living in both rural and urban areas of Africa, how do they manage their health? Well, a commonly used statistic, even my colleague Diana mentioned it earlier, is that 80% of African populations use traditional medicine as their primary form of healthcare. This is true not only in rural areas, as you can see in the picture on the right. All of these plants were collected just by one woman on her way to the interview with me, but also in urban areas such as the capital city of Libreville, Gabon, and also in Benin, as Diana mentioned. Now, with such a large part of the population using these plants, and given that traditional medicine is so closely linked to spirituality, religion, economics, what are the issues? Well, there's limited research linking reproductive health care and traditional medicine, so it's not known which species women are using, what they're using them for, and also what effects that these plants may have on women's bodies, the risks, the benefits, and more generally, women's knowledge is largely understudied, even in the field of ethnobotany. These conditions led to my following research questions. Number 1, do women know plants to treat high blood pressure, hemorrhage, and sepsis? Number 2, which percentage of plants are used to treat locally determined issues, and what are the local conditions that are most important to women on the ground? Lastly, how do the local biomedical healthcare providers, so local gynecologists, midwives, doctors, how do they perceive the use of traditional medicine, and what are their experiences with women who use plants prior to arriving at modern hospitals and clinics? These 3 questions were investigated in the backdrop of 2 floristically and culturally diverse countries, Benin, West Africa in 2011, and Gabon, Central Africa in 2012. Working within the guidelines of the SEB Code of Ethics, we conducted 86 questionnaires, which were completed with women in rural areas, urban areas, and also on the market. Resulted in the corresponding collection of 800 botanical specimens. So immediately after each one of the questionnaires, we went with women into the field to collect the mentioned species, and in the market interviews, we purchased the plants that were for sale in the herbal stalls. Lastly, we interviewed 18 biomedical healthcare providers. So again, these are the gynecologists, the midwives, both at national hospitals and in local clinics in rural areas. Moving to the results. If you remember, the aim of my research, number 1, was to capture women's perceptions. We did this in the use of a free listing exercise at the beginning of our questionnaires, in which we asked women, what are the major causes of maternal suffering? And out of 46 respondents in Benin, the top complaint was malaria, specifically related to pregnancy. Secondly, was pregnancy related. Now, pregnancy in itself, of course, is not an illness, but there's a range of times throughout a pregnancy in which she's concerned about the health of the infant and her own health. And lastly, infections, which interestingly corresponds with WHO statistics with sepsis being a major cause of maternal mortality. In Gabon, we completed 40 questionnaires altogether with menstrual-related, and coming up as the top complaint. And menstruation, much like pregnancy, of course, is not an illness. But in both of these regions, menstruation is seen as a measure of a woman's health. So if she's having regular menstruation, if it's not painful, even based on specifics such as the consistency or even the color of her menstruation, this is a gauge in local terms of how healthy she may be and if she's able to have children, if she's fertile. Secondly, stomach ache, and lastly, infertility came up as frequent health complaints in Gabon. The second part of my aim was to capture women's knowledge on how to treat specific health ailments. And this was measured in two different ways. You can see the number on the left-hand side are, in both countries, the number on the left-hand side are the number of citations, so total citations out of 46 respondents in Benin and the 40 in Gabon. The number on the right-hand side in parentheses are the number of women who know at least one recipe to treat each health ailment. And I won't go through them all, but if you look at the top, things such as anemia, breast milk stimulation, pregnancy, and menstruation are all very high. However, you also see high blood pressure coming up and postpartum hemorrhage, so women do know how to treat these health issues. The last part of my aim was to capture the plant use practices, so which plants are women using. And in a similar comparison, you can see the number on the right-hand side is the total number of species that are used to treat each health condition, and then the percentage of the total number of species in each country that we found to treat women's health, reproductive health-related problems. It's a similar list. You can see pregnancy, menstruation, and anemia coming up pretty high, as do high blood pressure and postpartum hemorrhage once again. So there are quite a few plants that are used to treat both of these WHO-defined women's health problems. Concerning the local biomedical providers that we interviewed, well, number one, they recognized the role of traditional medicine in their patients' lives, and they realized that women quite often use plants or self-treat or use traditional medicine prior to arriving at clinics or more modern forms of healthcare. However, they expressed concern about the use of traditional medicine for health ailments such as abortion and birth facilitation. You can see the picture in the bottom corner of Sidaquito, which is in the Malvaceae family. This species is used to facilitate childbirth. And unfortunately, some of the doctors at a hospital in Libreville said that these plants sometimes work a little too well and result in uterine rupture. So there are some risks involved with traditional medicine. However, the local biomedical providers, healthcare providers, are not able to advise on traditional medicine, largely because of the government policies of not being able to discuss traditional medicine or use traditional medicine in hospitals. So there's a disconnect between what local women are doing and what the local biomedical response is able to do or discuss. A few points of discussion. Some of the local health perceptions that came up quite high on all of our studies. Number one was menstruation. And in spite of the fact that there are 350 million women menstruating at any given time, there are virtually no programs in international health that deal with menstruation. This is an issue, of course, of hygiene and infection, but also a productivity issue. If young girls aren't able to control their menstruation or effectively manage their menstruation, then they're not able to attend school. And also adult women, it severely lowers their ability to be productive in the workforce. Secondly, infertility, and this is maybe the opposite of what you hear of a lot of health programs in Africa, where there's a big effort to increase contraceptive use, to reduce the number of children that women are having. Studies have shown that up to 30% of sub-Saharan couples suffer from either primary or secondary infertility. So this is a documented cause of maternal suffering, also psychological suffering, social suffering, if you're in a community where fertility is valued very highly, and if the rest of the women in the community are able to have a lot of children. And lastly, vaginal cleanses. And this can be a whole range of plants that are used post-menstruation, post-sexual intercourse, right after pregnancy, after childbirth. However, there's not a lot of information known on how these plants are actually affecting women's bodies. If there's perhaps, because there's multiple ways of using the vaginal cleanse. In Gabon, for example, there's something called faire les ovules, when you take the leaves and make it into a small ball and you actually insert it. But there's not enough known about the plants and what they're doing to women's bodies. However, this is a really locally important health concern, and it's not something that, again, healthcare programs really talk about. So in conclusion, yes, women do use and know plants to treat the top causes of maternal mortality. However, the vast bulk of their knowledge and the vast bulk of the plant species relate to the everyday management of menstruation, pregnancy, and childbirth. More generally, reproductive health programs can be improved by including local women's perceptions, specifically such things such as menstrual health and infertility. And lastly, plants really are the entry point to understanding local health management in both Benin and Gabon. However, more research is needed on the effects that these plants have on women's bodies, and more effort should be taken to better integrate local traditional medicine practices and biomedical health care. A long list of acknowledgements, which I won't go through, of course, a few references, and at this time I welcome any questions. Thank you.
Yeah, thank you. Yeah, it's moving fast.
Me again?
Yeah?
Okay, really interesting. Thank you so much. The women's perceptions in Benin, they refer to sepsis, you refer to sepsis, that, infection. Gabon, fertility issues, possibly, clearly, maybe related to sepsis again. And yet, the biomedical profession were concerned about plants being used for abortion and plants being used for birthing. So do you think that there may be some socio-cultural background to biomedical professionals that they're not actually recognising women's real concerns because, their concerns were actually, the women's concerns were actually about real physical illnesses which they needed help with, but yet the biomedical profession didn't seem to recognise them.
Right, and also a lot of the statistics are based on maternal mortality. And that's a different story than just general everyday health ailments or even morbidity. And so with international programs, and again there's a difference between the international perspective, the local biomedical perspective, and African women themselves. There's actually three different players involved in women's health, and it's that lack of communication and understanding in between the three that resulted in a lot of unfortunate mismanagement of health.
Yeah, somewhere back there, I can't see a face, but there's a hand. Yeah, Julia. Yeah.
Thank you, that was very good. I'm curious why you chose these two populations. Is there something about them that's interesting for comparison, or what kinds of differences can you talk about? Or similarities?
Yeah, thank you for the question. It's actually quite important in some ways. Both countries, there's a strong use of traditional medicine to begin with. However, on all the other levels, they're very different. Floristically, totally different countries. Where Benin, as Diana had mentioned, is mostly savanna. Gabon is about 80% forested. So different plants altogether, different ethnic groups, of course. Different religions. Everything else is quite extremely different about the two countries. And as a side part to that, I work in a larger research project comparing West African and Surinamese plant use. And so those were the countries, along with Ghana, that are included in this larger research project.
Final question? Yeah, yes, please.
Thank you very much, really interesting. I'm curious in the whole health issues of plant use and women's health. There was nothing cited about women and the menopause. I'm wondering if that link that came up in the research into women whether plant use was even mentioned. This is quite topical in the UK at the moment. How much is this even mentioned?
times in questionnaires where they were semi-structured, where I would ask about specific illnesses, and then I would ask, is there anything that I forgot? And then oftentimes in the plant walk, additional ailments or additional plants would come up. And I would say maybe out of both countries, there were maybe 5 informants altogether that mentioned something related to menopause. So from the local perspective, I didn't find a lot of it. I worked primarily with mothers and grandmothers, and so it's sort of the full range of women. But I didn't find anything specifically related to menopause, enough to really bring it out in the research.
Okay, thank you very much for a very stimulating talk, and sorry that we have to move on.